You're watching CTOM TV. Knowledge is power.
Some patients we have been, they've had smoldering, what they call smoldering multiple myeloma. They've had that for many years and it's never progressed. They've been able to keep it in check with lifestyle. Lifestyle is a huge factor in smoldering multiple myeloma. There's a lot you can do. You want to get a lot of exercise. You want to clear out your system. You want to, really take good care of yourself.
Okay.
So smoldering multiple myeloma is the big issue. And so they have this protocol that they've been using for a long time called CRAB. And that refers to increased calcium, renal failure, which is your kidneys, anemia, and then bone lesions. So when you start having an increase in these, then they start treating you. And the typical treatments have varied over the years. And the goal is obviously to get a stem cell transplant. And that's one of the best ways of treating most of these diseases.
Is there some reason why they just wouldn't start with that? I mean, aside from cost, if we took money out of the factor.
There's many reasons. They do try to start with that, but in order to get to a place where your body will respond to that, you have to have your tumor burden down very low. And that's the key.
And so the lifestyle.
And they can tell a lot too by how well you're going to respond to a stem cell transplant by how well you respond to your initial chemotherapy. And that's kind of the goal of that.
So everybody starts on standard chemotherapy? Is that what you're saying? That's kind of the standard
That's kind of
care?
the standard, yeah.
Okay, and then if you respond well.
Right.
Okay.
Right. So recently, as of 2018, the Mayo Clinic came out with a wonderful new protocol for determining when to treat people. So the CRAB protocol is to try to determine when to treat someone with smoldering multiple myeloma.
Okay.
So the CRAB protocol obviously does not take into account certain things like high risk. And high risk are, genetic features. So high risk patients, genetic features such as, let's see, I wrote some of these down. So the translocation of chromosome 4, it's called the 414, deletion of the 17p chromosome, or a gain of a 1q. And each of those are high-risk genetic factors. So you want to know that.
Can you repeat those?
So it's a 414
translocation,
a 17p deletion, or a 1q gain. And so the p and the q are just different arms of each chromosome.
I see. Okay.
So each one of those, if you have smoldering multiple myeloma and you have one of these, then you're going to be in the high risk category.
Okay.
And that means you have a really good chance of not staying in smoldering for very long. You're going to progress quickly and you're not going to respond well to treatments. So
are we still talking standard treatments? Are you about to tell us, wait, there's more? Or is this
we're not there yet.
Okay, all right.
So once again, we're at smoldering.
All right.
And when to treat and why to treat. So that is the problem with CRAB. Is it doesn't take into account the high risk genetic features.
Right.
And so you have to get a genetic sequencing for that, cytogenetics. So then the Mayo Clinic in 2018 came up with a wonderful new protocol. They call it the 20-20-20, or it's actually 22-20. What that refers to is a bone marrow plasma of 20% or more, an M protein, which is a protein that's used in diagnostics of multiple myeloma, an M protein spike of greater than 2 grams a deciliter, and then a free light chain ratio of greater than 20.
Okay.
So those are the new criteria for high risk in multiple myeloma when you have a smoldering situation.
So they still do the CRAB thing, but they also do this.
Yeah, this is kind of determining, this is in addition to the CRAB.
Okay.
So this helps if you're following the CRAB protocol or the CRAB diagnostics, then you want to include
The
this
22-20. Got it.
Because it will allow you to determine, which one of these patients are high risk and which should be treated quicker.
Which could also be determined by the genetic testing?
Yes, genetic testing,
Okay.
yes. So the big thing over the years, and we've been advocating for this for a long time, we believe that treating high-risk smoldering multiple myeloma patients is the best way to go. And a lot of doctors have been very reluctant to do so, just because they don't necessarily grasp the concept of what's high risk and what's low risk, and what the benefits are. And so now we have some great studies that show that adding, do you recall thalidomide?
Yes.
We discussed it. So it also plays a great role in multiple myeloma as well as lymphomas. And so the way it works is the thalidomide class of drugs, and there's actually 3 of them now. They've changed them and they've adapted them so they're more specific to cancers. There's lenalidomide, there's thalidomide, which is the original one. Lenalidomide was the next alteration of it, the 2nd generation version of it. And then there's pomalidomide, which is the 3rd generation version. So the way these drugs work is they inhibit a process called angiogenesis. And angiogenesis is the mechanism that cancer cells use to recruit blood vessels to grow and metastasize quicker. Because they're so highly metabolic, they need to have a really good blood vessel system. Unfortunately, with angiogenesis, it's not a complete development of a blood vessel system, and they miss, I think, the 7th or the 8th stage of blood vessel development from neogenesis. So as a consequence, you end up with leaky blood vessels. Sealing of the blood vessels is one of the last stages in the development of a new blood vessel. And in angiogenesis, you have kind of leaky blood vessels, and that really helps the tumors grow and metastasize.
So the thalidomide and the other 2 help to stop.
They inhibit angiogenesis.
Got it.
And that is probably part of the mechanism of why they cause birth defects too, is they probably inhibit the processes involved in growth and development.
Yeah, makes good sense.
Yes. So while it doesn't work for pregnant women, it seems to work quite well for cancer. And so they also work. They also increase these drugs called interferon, or these molecules called interferons. And the ones they interfere with is interferon gammas. They increase interferon gamma 2, 10, and then they downregulate 6, I believe it is.
And what does that mean?
These are just pathways that cancers use
I
to grow
see.
and metastasize. So they actually have some specific cancer pathway effects, as well as inhibiting angiogenesis.
Wow, that's actually
So to circle back with smoldering multiple myeloma, we found that there's a recent study that shows that if you have smoldering multiple myeloma and you take lenalidomide while you're smoldering, in other words, treating before you actually have full-blown disease, you get a 78% risk reduction, which is huge. So, we've been advocating for treating smoldering for many, many years. The data has been shaky. It's been hard to determine who to treat, but it's just a common sense thing. You treat the disease at an early stage before it gets its heterogeneity, you're going to have a much better, much longer lasting effect. So rather than, waiting until you have full-blown disease to treat it with targeted therapies at an early stage, and then rely on chemo at a later stage. So in the beauty of this study of adding lenalidomide and dexamethasone, the beauty of this is it works better in high-risk patients. So those high-risk patients that we were just discussing, so they have a 90% reduction in death and disease.
Whoa!
Yeah, so that's pretty significant.
Yeah, let's talk about that. I feel like I missed something in there. You mentioned Dex something or other.
It's just a steroid that's normally used.
A steroid, and that helps with the interferon somehow, or what? What does that do?
No, that helps with the lenalidomide. It's dexamethasone is used in treatment. It was one of the first treatments for multiple myeloma. So it's just a steroid. It's not really considered a cancer-fighting treatment. It's more of something that deals with the side effects of cancer, but also in that process, it reduces the overall progression of the cancer.
So let me make sure I'm following you here. If you are a multiple myeloma patient or smoldering multiple myeloma patient, and you have some of those high-risk factors that you talked about.
And even if you don't,
Even if you don't, you're 78%.
Yes, risk reduction
And
and progression.
Yeah. And 90% of you do.
Yeah.
So that it's actually kind of becoming a good thing to have some of those high risk factors in some twisted way.
In some twisted way, yes.
Wow.
And so, you may want to ask what the risk is for progression.
You mean your personal risk based on those factors?
So if you have, low risk disease, you have, I think it's about a 5% risk of progressing within 2 years. If you have intermediate, it jumps up to about 17 to 20% risk over 2 years. And if you have high risk, you have at least 45 to 50% chance of disease progression in 2 years.
So either way, if you can make a sound argument for early treatment rather than watch and wait, your percentage of likelihood of success of treatment or longer life is 78%
it's
to
pretty
90%.
Significant. Yeah,
that's outrageous.
And there was another trial on that too. This focused on high risk patients, and it based the high risk on the Mayo protocol that we said, the 2020. They use that as a guide, and that's kind of where they developed it. It's called the Q-Redux trial. And so it was just for high risk. And they found that in patients, when they gave them this lenalidomide and dexamethasone combination, for these high risk patients with smoldering, the progression was not reached in the trial versus 23 months in the non-treated patients.
For those at home, what does progression not reached mean?
Well, when you're in smoldering, when you get the progression of the disease.
So it means you haven't even started to show disease then.
No,
or it's not
you
growing.
have the disease. It's called smoldering.
Okay, so it's there.
Yes.
Doesn't the treatment take it away?
Yes. I'm not sure I understand what you're getting at.
Neither do I. So what you were saying is there's this certain, if you could just say it again for what you were saying, the smoldering, the progression, the reduction.
So when you have smoldering multiple myeloma, you have if you have low risk, then you have a 5% risk increase in 2 years.
Got it.
If you have intermediate disease, you have a 17 to 20% risk. And if you have high risk disease, you have a very high chance of progressing within 2 years. And so that means that, you're not going to have a good outcome if you have high risk.
Okay.
So when they took this group of patients with high risk and they gave them this Lendex, rather than not giving them any treatment whatsoever, the progression was not reached in the Lendex in the first period of time versus 23 months in those that did not get the disease.
Okay.
Did not have the treatment.
So standard might be 23 months then. And by the time 23 months passed, these people hadn't progressed.
Exactly.
Okay, thank you. That's what I was trying to understand there. Okay. And that was with what treatment?
That was with the Lendex.
Okay. All right. Wow. So that's pretty exciting. Now, how long have these things been around? Like, when was this study that had those numbers? 78% for low risk, 90% for high risk?
Well, they haven't focused on smoldering, and that's the problem.
Oh.
That's the whole thing.
Because they're not really thinking.
Well, they don't understand the risk factors, and that's what we discussed in the beginning of this conversation. Is smoldering was the big issue, and having that, deciding when to treat these patients is really what it's all about.
Got it.
And should they be treated or not?
So the genetic testing to see if you're in
High
any
risk.
of those 3 high risk categories,
or the 20-20-20.
Yeah, got it. So you want to make sure that those options, or you're getting that kind of diagnostics as well as the crab.
Exactly. Yes.
Okay.
So the crab is not enough.
Yeah. Okay. That's the fundamental point, I guess, that you're trying to make.
Yes.
If your doctors deciding on treatment based on crab alone, no.
No. So, it's important to speak with your doctor and make sure they're following, this new criteria, 20-20-20 from the Mayo Clinic. Yeah.
Yes. Okay.
Yeah, and that they are looking at genetics.
Yes.
And they have really defined whether you're high risk, low risk, on genetic basis. That's so important.
Because 90%.
And then why not get treated, even if you're low risk? Why not?
Exactly.
With such a reduction, the side effects are minimal.
Thank you for watching Ketome TV. Subscribe below and stay informed.